So this is the talk for optometrists on allergy, and I also throw in a few red herrings because I think there is a lot of that goes on with allergy. It's directed again for optometrists, primarily those doing independent prescribing, and I have said before that this should be watched after the one I did on immunology, because as I'm always saying, allergy is a reflection of immunology, and if you don't understand immunology, I'm not sure how you can really fully understand allergy, and certainly that would mean that you wouldn't necessarily be able to treat it quite as well as you could. Again, there's a lot of words in here. It was written originally without voiceover, so I've tried to create a bit of a narrative in it, and again, it'll allow you to just go back and read them if you want to. So we'll give you a little bit of history. We'll talk about the term hypersensitivity, which is both protective and injurious. And then, as I've already said, allergy is a direct reflection of the natural protective responses of our bodies, papillary versus follicular responses, antibody versus cellular responses. And then we'll introduce you to these two chaps called Gell and Coombs, the Gell-Coombs categorization of allergy, type 1, type 2, type 3, and type 4, which as optometrists, we're talking about these all the time. We may not know it. You may not have heard of Gell and Coombs. And then non-allergic triggers to inflammation, which I think are really important because we seem to call everything allergy. So understanding immunology allows us to understand allergy. And if you understand allergy, you can treat it much more effectively. So here is some helpful reading. All of these have been used in here somewhere. The one that I'll draw your attention to mostly is Wood at the bottom there, Understanding Immunology, because he takes you through, it's a really readable book for non-immunologists, right? And it takes you through all the immunological processes and then leads on to allergy as well. So it ties it all together rather nicely. So a little bit of history helps. The word allergy was first used by a character called von Perke. I'm not sure that's how you say his name, von P to the rest of us, to denote both host protective and potentially host injurious immune responses. So similarly, he described hypersensitivity as the status of a mammal after exposure to an infectious agent. The mammal is then hypersensitive to that agent and is therefore able to deal with it effectively on second exposure. So there's nothing in what von P suggested that reflected adverse reactions. And indeed, what he's describing there in the second section is actually describing the acquired immune system, isn't it? So he developed the principles, and he was quite a famous chap, and he still is famous in immunological circles, even though he's not particularly well known in optometry circles. And this guy, Rajan, emphasizes that, and I think this is important, evolutionary speaking, we don't come up with things just to cause us a bit of pain, right? The evolutionary emphasis is to benefit survival. And so again, it's important to consider hypersensitivity in that sense. So if we understand inflammation, we've got the essential body defenses, the innate and the acquired immune system. And if you understand them, then you can understand allergy, which is the normal immune processes triggered inappropriately. But since von P, there were these two chaps called Gell and Coombs who in 1963, so this is like, this is 60 years old now, coming up, developed their classification of what they called hypersensitivity reactions. And this certainly emphasized the deleterious effects. And so since then, the terms allergy and hypersensitivity have acquired this connotation of purely deleterious responses, which Gell and Coombs didn't intend, but that's how it panned out a little bit. And I think we have to always think of that. So in this lecture, I'll be using the Gell-Coombs categories because they are still widely presented, including in the clinical management guidelines, but they can be somewhat confusing. and I'll put your minds at rest about that, and hopefully I'll put your minds at rest anyway, and we'll explain it as we go. And this is the first thing. Do not be alarmed, right? This is written by this particular chap. This classification has bewildered countless generations of medical students who have found it difficult to pigeonhole immune disorders into this classification. And it's true. And when I read that, it put my mind at rest a lot, because what happens is you'll read one, say, textbook, and it'll say a certain thing is this sort of response. And you read another one and it says it's another one. And you think, and I'd spend my time just going around in circles trying to figure out why they were saying this. Well, the bottom line is it's very, very difficult to categorize almost anything. And so when I read this chap's comment, it put my mind at rest. And I will be demonstrating this with examples. And accepting this very fact will save you a lot of heartache while you're studying, and a lot of angst when you do read apparently contradictory classifications of the same disorder. So the gel Coombs, we will stick to this. Now remember, it's 60 years old now, but it was still pretty groundbreaking stuff when it came out. And we talk about type 1, type 2, type 3, and type 4 allergic reactions. So type 1 is the classic type 1 IgE hay fever type thing, which is, it's the only reaction that involves IgE, which if you remember from immunology lecture. Type 2 is an antibody-dependent cytotoxicity. Type 3 hypersensitivity is a deposition of antigen-antibody complexes. Now, both of those processes involve antibody, but not IgE. And then there's type 4 contact hypersensitivity, like poison ivy, and this involves T cells and not antibodies. And that is almost a clear reflection of delayed type hypersensitivity that we've talked about in the last lecture. So type 1 first, hypersensitivity, that's allergy. And, you know, like all antibody-dependent reactions, sensitivity has to be acquired. It's the acquired immune system going a little bit rogue. So the first contact primes the IgE. So we go through all those usual things: clonal expansion or clonal selection, clonal expansion, class switch, affinity maturation, and so on. And then the primed IgE, in this case, like IgA is we tend to call it serum based because it's fluid, it's in the fluid. IgE attaches to mast cells, and on the second presentation causes the release of all its usual inflammatory mediators. And so again, this is the innate inflammatory process being triggered by IgE inappropriately. The evolutionary benefit is that it suggested that it would protect against multicellular parasites. If you remember ADCC, you know, they do attach to the actual thing they want to destroy, and then the mast cell degranulation gives you the vasodilation, the increased vascular permeability, goblet cell activation, smooth muscle contraction, and so on. So there is obviously an evolutionary benefit to IgE. It's just that we seem to have lost the reason to have it, and therefore we just always seem to think of it as a rather rogue animal. So common allergens would be pollens. We know all this: insects, dust mites and stings as well, animals and birds, dander, feathers, drugs. Some drugs will do this. Some drugs will also produce a different sort of allergic reaction, which we'll come on to later, type 4, and some foods, of course. Now I'll just show you what happens is, of course, the IgE locks onto the mast cell after it's been primed, as we've said, and in comes the pollen, say, and bang, it degranulates and instigates the inflammatory innate response, but only to that very specific allergen, of course. But in a local sense, you know, or local and systemic, we've got asthma, rhinitis, allergic eczema, and actually as IPs, we can deal with that. I certainly deal with allergic eczema. Diarrhea, systemic anaphylaxis, of course, is the big one. And then we've got our allergic conjunctivitis. Now, seasonal allergic conjunctivitis and perennial allergic conjunctivitis are quite clearly type 1 reactions. The others aren't necessarily, and we'll get onto that in a minute, but they're possibly not. And also we draw your attention at this point to some of our more common red herrings. Diarrhea certainly can be a sign of an allergic reaction, definitely. But it can also be the sign that if you've taken a penicillin and it just happens to have knocked out all of your gut bacteria, then you'll get diarrhea. Now, that's not necessarily an allergic reaction. Well, in fact, indeed, it's not an allergic reaction. It's an adverse drug reaction, quite clear adverse drug reaction to taking a penicillin. And the other one, of course, is mast cells can be triggered by so many different things, including trauma and toxicity. So a suture rubbing on your upper lid when you've had cataract surgery, say, can produce an inflammatory response, but based on trauma and also toxicity. And I think that toxicity is quite a common one. We're often talking about allergy to benzalkonium chloride. Well, it's a toxin. And most times I don't think we are having an allergic reaction to that. And I'll come on to this much later on, is pure toxicity causing damage to the eye. So we'll come on to those. Now, so as we've said, the good old mast cells preformed and preloaded. And once that pollen or dust mite or whatever causes degranulation of the mast cell, bang, we've got the entire innate immune system kicking in, histamine, enzymes, chemotactic factors that are already preformed inside, but then it also produces more things, more tumor necrosis factor, platelet activating factors, leukotrienes, prostaglandins, which of course are let's make a point about this now. They're pro-inflammatory mediators, obviously, and therefore when it comes to the glaucoma lectures, their mode of action is really important to certain patients that you may not choose to use them on. So in a localized sense, we've got asthma, we've got rhinitis, and we've got skin allergies, things like hives or chronic or allergic eczema. And, I do deal with these. I quite fairly regularly deal with allergic eczema and so on. So they're all the sort of local ones. And I think the rhinitis is rather an important one to talk about, because if someone comes in and say, do you have any allergies? And they say, yes, I get hay fever. Well, you should be saying, next question should be, well, how does it affect you? It's no point just writing it down and moving on. That sort of doesn't help. And sometimes I might say, well, it's just I get a runny nose. So they've got rhinitis. But if they don't have itch as well, then you probably don't have to carry it that much further. And systemically, we've got food allergies. And also the big one is anaphylaxis, where when you go into anaphylactic shock, it's because every mast cell, let's say, every mast cell in your entire body is just exploded, and all the fluid you've got hypotension, all the fluid plasma is just into the tissue. You get swelling of lips, tongue, larynx, you've got nausea, you've got asthma, because the whole thing throughout your entire body is causing all the inflammatory responses. So you've got nothing left, loss of fluid from the blood into the tissue, and then circulatory collapse and death. So it's fairly aggressive. So considering allergic conjunctivitis first, like seasonal, the clue's in the name. It does not say anywhere in the title keratitis, right? And here's our first red herring. When diagnosing and treating this, that's the clue. Unless it's extremely severe like AKC or VKC, the cornea is not involved. So you put your fluorescein in, it's clear. If you've got a lot of corneal epitheliopathy, it's most likely toxic microtrauma. So again, if you're dumping a whole lot of benzalkonium chloride in your eye, you're going to have a gritty, irritable eye that is going to show trauma, effectively microtrauma of the conjunctiva, and that is clearly not an allergy. And also, it is important to know that, really, because you're going to treat it different, isn't it? You know, inflammation, allergy, you're going to treat in a different way to trauma. Now, Medscape is a really good resource. It's American, so sometimes the drugs vary, and you do have to register with it, but it's free. It's great when you're researching this stuff. So basically, I use different resources to show you how perhaps different authors have different opinions on what sort of allergic reaction it actually is. So Medscape say there are 5 allergic conjunctivitis. There's seasonal allergic, perennial allergic, atopic keratoconjunctivitis, vernal keratoconjunctivitis, and GPC. And they also suggest, this particular author also suggests it may be implicated, IgE may be implicated in oculocicatricial pemphigoid and Murine ulcer. So this is the thing, while Sack and Pack can be clearly categorized as type 1 IgE allergies, VKC, AKC, and GPC cannot be so easily pigeonholed. And this highlights, again, this problem with the Gell-Coombs system. And remember what Rajan said, this classification has bewildered countless generations of medical students, right? Because it's bloody hard to knock everything into these 4 holes. Now, whenever something comes up in yellow like this, this is my opinion, right? You do not have to take it. But the more I get into this stuff, the more I think about it. And if allergic reactions and autoimmune diseases reflect normal beneficial defense mechanisms that have gone wrong, and as we fully now appreciate the myriad mechanisms that the innate and acquired systems utilize, it's little wonder that the Gell-Coombs categorization cannot deal with everything. You just need any of those many avenues within the immune system to go rogue, and you're going to come up with a dodgy result. So it's not always easy, I think, to categorize like that, and you've got to realize that. But at the same time, I do think it was groundbreaking stuff. I mean, in 1963, to come up with the chemical and biochemical strategies that they used, it was mind-breaking stuff. So, and for most community or clinicians, it's enough to recognize that all these things manifest as inflammation. And I think that's the point. As I'll say at the very end, if we can differentiate between inflammation and trauma, or anything else for that matter, then we can deal with it. So let's get on to the college's clinical management guidelines. And they have one on seasonal allergic conjunctivitis and perennial allergic conjunctivitis. Now, here's my other thought. And, you know, Sack and Pack, the differentiation is totally arbitrary, you know. Always think of this, the process on the eye to the human being involved, it is exactly the same process. It is simply the trigger's different. And so if it happens to be pollen, then yes, we can call it hay fever, and that's why it's seasonal. But if it happens to be a cat that you own, it could happen all year round, so it's perennial. But the trigger is exactly the same. Or sorry, the trigger is not exactly the same. The reaction in your body is exactly the same. And of course, if you know the trigger, then you can actually solve the problem, generally speaking, by avoiding it. You know, if you know it's a certain animal, avoid the animal. Obviously difficult to avoid summer, but you know, so long as you can avoid those things, you can control most things quite successfully. So here's some snippets taken out of the clinical management guidelines for Sack and Pack. As I've already reiterated, they just say it is quite clearly type 1. They don't give any other variations. It's a type 1 hypersensitivity reaction to specific airborne allergens. Seasonal allergic conjunctivitis is caused by seasonal allergens, and perennial is caused by non-seasonal allergens. Easy peasy. If only it was all like that. The signs: mild to moderate edema of the lids, periorbital edema in severe cases, and actually I'll show you a case at the very end with that. the bulbar and tarsal chemosis and papillae. And as we said in the immunity lecture, chemosis and papillae are just flip sides of the same thing, but the cornea is uninvolved. So again, remember, it's just too easy to call everything allergy. And sometimes, people say, well, what's happened there? You'll talk to students and they'll say benzalkonium chloride. Oh yes, it's allergy. Well, it's not. So with sac and pack, you've got your classic preloaded mast cells sitting there, all nice and comfy in the innate immune system. You get your IgE that's been primed via first interaction to that specific pollen, say, and it comes down and becomes membrane bound to that mast cell. And if a pollen comes in, bang, it erupts and instigates that inflammatory response. So basically, type 1 allergy is the innate immune system triggered. It's non-specific inflammation, hence it's a papillary type reaction. And a papillary type reaction is going to be, in my opinion, more likely when it's chronic. And it could also show bulbar chemosis, especially if acute. So if you get an acute eruption because of something, you might be more likely to see chemosis. Whereas papillary reaction, as I've already said in the last lecture, it tends to be fairly structured. It's technically fairly architectural, and it takes slightly longer, in my opinion, to evolve. But once it's there, it stays. So AKC now, more complicated little blighters. The signs, eyelids may be thickened. This is all out of the College of Optometry Clinical Management Guidelines, which you all know you have to know. The eyelids may be thickened. Tarsal conjunctiva, you'll have GPC, really giant papillary hypertrophy. You'll have subepithelial scarring and shrinkage. The entire conjunctiva is hyperemic, limbal inflammation, and corneal involvement is quite common, beginning with punctate epitheliopathy. So this is a much more aggressive piece, and I don't think in the community we would be dealing with this. I think this is a chronic problem, and in my time I deal with a lot of very, very severe sacs and packs, but this sort of stuff you'd really probably be wanting them under ophthalmology because they do need a lot of ongoing care. And of course, if the cornea is getting compromised, it's pretty serious stuff. So the college suggests this is a complex immunopathology including T-cell mediation. So, they're saying it's a type 4 hypersensitivity. Medscape, on the other hand, say it's type 1. So I'm more inclined, look, it's not that I'm on the college's side always, all right? But my understanding of all this, I'm more running with what the college is saying. I can't see how this really could be a type 1. There's probably type 1 in there, but I think it's a far more complex animal than that. And again, that conflict between those two, or the apparent conflict, reflects the complexities of immunology and the difficulties trying to crowbar reactions into a Gell-Coombs category. But they tried, bless them. But they can't both be totally right. VKC, I'll use a different group to compare to. So the American Academy of Ophthalmology says that originally thought solely an IgE reaction. It says IgE is not enough to cause the varied inflammatory responses seen with VKC. And I think we'll have to agree. They suggest that activated eosinophils play a significant role, mononuclear cells, neutrophils, and CD4 T helper cells drive a type 4 type hypersensitivity. Right, excellent, right, okay. The college say it's a complex immune reaction with raised IgE levels. So, if you measure it, there are raised IgE levels in the tears. which I don't know, maybe you'd expect that, mast cells and eosinophils in the conjunctival epithelium. So those sorts of cells are certainly activating in some way. And okay, with the college, it could be partially due to IgE activated as well. But the signs, stringy white mucus, hyperemia and chemosis of the conjunctiva, 1 active, and GPC as well. And with the cornea, though, you're now getting superior punctate epithelial, but macro erosions, which must be, pretty serious, and plaque deposition. So it's a far more complex thing than we deal with sac and pack. Now GPC, let's see, Medscape. It's an immune-mediated inflammatory disorder of the superior tarsal conjunctiva. It says it's a combination of type 1 and type 4 hypersensitivity reactions. Right, okay. The college say, and I know I showed you this at the very beginning of the immunology lecture actually, they suggest it's a type 1, type 4 and trauma-induced process. So complicated, not fully understood really. Well, not fully understood when you try to crowbar it in Gell-Coombs category. And what about number 3? The trauma is really important. And I think we let it go too easily. We're always trying to say it's something allergic when it could be as simple as just trauma. So with GPC, you've got to remember, it could be triggered by a dysfunctional acquired immune system, IgE. A contact lens protein, for instance, and it still produces the same result. It's just triggered, the mast cells degranulating, whichever way it's happening. But, again, as we've already said, anything else, trauma, that could trigger mast cell degranulation as part of the innate immune system would elicit the same reaction. So with GPC, my personal view is that with our modern contact lenses, with us replacing them daily and so on, back when I started out, yes, you'd put this humongously thick, soft contact lens in, and they'd want to make it last for about 3 years if they could possibly pull it off, because it cost them a lot of money to buy in the first place, and you'd get all this GPC going on, and dang, it was difficult to get rid of, because we weren't allowed drugs. You're telling someone who's bought a really expensive contact that can't wear them anymore. You think, wow, we weren't really being clinicians back then. We were contact lens fitters, and we created the aftermath, and we couldn't fix it when it arrived. Anyway, that's me just ranting. But certainly it could be elicited by any sort of thing with trauma, and I think trauma is as likely with GPC, microtrauma, chronic microtrauma, as it is with anything else, like a suture. So the college says the signs are almost always bilateral. Now, here's where logic comes in. We need to be thinking logically about what we're seeing and what we're doing. The upper tarsal conjunctiva, we get papillae, we can get hyperemia, stringy mucus if it's really bad, and conjunctival edema. Now, first of all, it's only going to be, well, yes, it most likely, but it depends on the trigger. So if the trigger happens to be a suture, it's patently not going to be bilateral. It's going to be associated with that suture. And remember, papillae are a sign of the non-specific inflammation. And remember again, it does not have to represent an allergic response. It can reflect trauma. And they do mention conjunctival edema, which, let's be honest, that's chemosis. So again, remember what we said, it's another manifestation of the general inflammation, innate response. So chemosis is just swelling of the tissue from inflammation. Papillae, like I said, happen where there's a tighter junction between the tissues. Whereas with the bulbar conjunctiva, it just balloons out. Gel-Coombs type 2 and type 3 reactions. I believe in the ophthalmological world we probably deal with this more than we think we do, but certainly in optometry I don't believe we do. So I've just got a couple of slides on these two to get through them. But type 2 involves the production of IgG antibodies rather than IgE. And they react to antigens on the host cells rather than foreign cells. The classic example being blood transfusion reactions, which are classically type 2. So back in Gel-Coombs' day, that was the one they were really trying to nail. And it leads to cell lysis and tissue damage. So basically it's activation of complement, if you remember back. So we've got cell lysis, opsonization, chemotaxis, and inflammatory mediators that reactivate the inflammatory process of mast cells and eosinophils. And then there's also antibody-dependent cytotoxicity, ADCC, where the host cell is killed by natural killer cells and macrophages. So some drugs also produce this sort of hypersensitivity, such as some textbooks will suggest that OCP is partially type 2, as well as some books telling you that it's type 1 and type, and so on. Type 3 is caused by immune complexes. So if you remember back to the to the immunology lecture, these things it's a protective thing. It's a way antibodies can neutralize antigens, so they agglutinate them into these clumps which cannot spread and can be more easily phagocytosed. But of course, if they become too big, they become these antibody antigen complexes that clog up blood vessels and create inflammatory responses. So if they're not cleared, they'll deposit in the tissue. And the physical bulk of the complexes compromise tissue function, but also inflammatory mediators are attracted in by complement and so on. So it's that sort of process basically. And so of course, if the macrophages are unable to phagocytose these immune complexes, they're trapped and they cause inflammation via degranulation of immune cells such as neutrophils, and it's more aggressive, unresolved complement response. So a potential ophthalmic example of a type 3 hypersensitivity reaction would be interstitial keratitis. And this is something I do deal with. We looked up Medscape. Interstitial keratitis is a broad descriptive term historically synonymous with syphilitic disease. But the article does further on that and say, well, the stromal inflammation representation can also be caused by a bacteria, virus, parasite, or autoimmune diseases. And that's where we deal with them, with viruses. This is where we'll see it with chronic long-term zoster and simplex keratitis. Now, I don't know if you remember, but there are 5 forms of viral keratitis, and we talk about the classic epithelial one. And okay, that's active viral infection of the epithelium. It starts with vesicles. It then moves on to be the classic dendritic format, and then if it doesn't get controlled, it'll morph on a bit more and become geographic. Then we've got interstitial keratitis. That's inflammation of the stroma, and it's supposed to be a reaction to viral antigen. And with these patients, if you ever see them or when you see them, there's no pain, it's just blurry. And the stroma is quite a demonous appearance as you're looking at there. Now always remember it, IK, interstitial, it's immune. So it's an immune reaction. Necrotizing keratitis, on the other hand, is stromal as well, but it is pretty much assumed to be active viral infection of the stroma, and it apparently is painful. So you wouldn't mistake the two. And then we've got endotheliitis, which is again an immune reaction in the endothelium, and you've got the neurotrophic type reaction when the eye has become desensitized. So this particular author, and I'll quite clearly deal with these, and we deal with the steroid, and you'll get these patients, and even if you're dealing with themselves, you'll have these patients in that are long-term zoster patients at the hospital, and they'll be putting, say, 1 drop of prednisolone in once a week. and it's just trying to keep down the interstitial keratitis. So this particular author suggests that there's three possibilities or three prongs to this. There's antibody antigen complex deposition, there's complement mediated disease, and it's a delayed type hypersensitivity reaction. So they're not even attempting to crowbar it into a Gell-Coombs categorization. Although if you looked at it, you'd say, well, the first one is probably a type 3, the second one's type 2, and the third one is a type 4 reaction. But again, when you think about the complexities of the immune system and how variations can go down, it's little wonder that we've got to start categorizing things in a more specific way as to what chemical and biochemical reactions we're seeing in the tissues as it's happening. So a Gell-Coombs type 4 reaction is one that I believe we do see quite a lot. It's called contact hypersensitivity, or it's delayed type hypersensitivity. And it is very much a reflection of the normal immune reaction of delayed type hypersensitivity we talked about in the last one. Poison ivy is a generic example, but it's to do with very small chemicals, which I'll explain in the next slide. And it creates these skin type reactions, swelling, redness, and severe itch, contact dermatitis. And it's delayed as it takes about 24 to 72 hours to manifest. And it's not simply because the acquired immune system lag. It's not actually to do with that. It's actually because it takes time for these really small chemicals to filter through the skin. So in fact, you could argue that this one's always delayed, right? As we said at the beginning of the immunology lecture, these antibody type reactions are generally only delayed the first time until we're primed. Then the reaction is immediate. But of course, this isn't an antibody-driven thing. So the small chemicals have to filter through the skin before the system can create it. So how does it work? These very small chemicals, such as chloramphenicol, they're too small to elicit an immune reaction on their own. They're just too small. So we use the term hapten is applied, right? And these small molecules, they bind to larger carrier proteins, our own human proteins, like a protein. And then that hapten protein combo generates the immune reaction. But the small size does allow them to penetrate epithelial cells, and that's the point. And so if the hapten then combines with this host protein once through the epithelial barriers, then the hapten protein combo creates the CS response. So remember, delayed type hypersensitivity is a protective mechanism, and it involves T cells, not antibody. So the chemical comes through the skin, gets attached to one of our self proteins, and that hapten host proteins are then taken up by antigen presenting cells and migrate to the lymph nodes, where specific CD4 T cells differentiate into helper cells, and they create a specific response. So hapten specific CD8 T cells are also stimulated, and this process, because it's processed in the lymph node factories, it is logical that the clinical observation is going to be follicular. So, you know, for me, when I was just doing my additional supply, really, I think, I was with an ophthalmologist, and he was talking about a patient who was allergic to a glaucoma drop. And he says, oh, well, it's a follicular. And I'm thinking, hang on, you've just said it's an allergic reaction. I was just, at that stage, I was still thinking every time you had an allergic, it had to be papillary, because I didn't understand what was going on before. So that was the start of my little process of trying to dig deeper and find out why the hell he said that, because I didn't want to look stupid in front of him, so I just accepted it, you know. So that's why, because it's a different process. So I want to use this next one as an example of how we've got to use logic to look at what we're seeing, look at it properly. So the example I want to use is dermatitis, and this is out of Medscape. And with allergic contact dermatitis, the tissue damage is an allergic substances is mediated through the immunological mechanisms. So you get redness and itch. And there can be a delay of hours or days before the symptoms appear. And now, okay, under these situations, you never figure this one out, but they may affect areas not actually contacted by the allergen because, of course, it's an immune reaction. It's not a direct contact problem, right? So medications, both the active ingredient and the preservative. So they do say it can be the preservative. So I know I've banged on before about benzalkonium chloride, but it can actually create this sort of reaction, benzalkonium chloride. It doesn't have to be just toxic, but you know, it probably is. But they can cause this sort of contact dermatitis. Now, irritant contact dermatitis is toxicity, and it would create a symptom that would reflect that. It's burning, it's stinging. We're talking about trauma. And the tissue damage is caused by direct exposure to the irritant, hence the burning and the stinging. And strong irritants obviously produce much more immediate responses. And importantly, they're only in zones directly in contact. You know, if you've put an irritant on your, it's going to be hurt, it's going to be damaged exactly where you put the irritant. And this contact dermatitis is arise as a result of the activation of the innate immunity without prior sensitization. So this is direct reaction. This is the normal innate immune system kicking in, and that differentiates it from the allergic one, which is triggered in that different way. And that's the red herring here, because appearances can be very, very similar. You've got someone with red scaly skin, you think, right, what is it? And the case history obviously comes in very handy, but also the symptoms, itch or burning. So this is where we come on to conjunctivitis medicamentosa. Now, I don't think it's inappropriate or wrong to question things. I'm not dissing the clinical management guidelines. I'm simply saying, as clinicians, we have a right to use our logic and consider it. And because if there's one that I have a bit of a problem with, it's this one. And it's a good term. It's, you know, and for what it's doing, it's describing it perfectly. It's a conjunctivitis created by medicines, basically. Right? So the etiology is chemical irritation. This is the college guidelines. It's chemical irritation or a delayed type hypersensitivity. So it does say it's those two mechanisms. So the chemical irritation is around the tissue or whatever, topically applied drug or cosmetic. And again, thinking about the contact dermatitis, it's going to be directly related to where you stick the chemical. Delayed type hypersensitivity is a topically applied drug, preservative, and they may be both toxic and capable of inducing a delayed type hypersensitivity. And then it goes through the symptoms. It could be irritation, ocular pain, stinging, burning. Signs, diffuse punctate staining of the cornea, and chronic epithelial defects due to toxic inhibition of epithelial healing if it's toxic. Okay, so it does sum it up very, very nicely. It is a recognized named condition. But I'm suggesting to you that that's describing two different things. It's describing at the bottom a type 4 allergy, but at the top it's describing toxic trauma. And patently you're going to treat those things actually quite profoundly differently. So I always believe these should be presented as two different animals. So let's look at one. This is a gentleman with blepharoconjunctivitis to Trussopt. So he is allergic to Trussopt. The cornea is clear and the hallmark symptom is itch. But he's still got puffy, scaly skin, but the injection is limited to the skin adjacent to the eye. Now, the conjunctivitis medicamentosa, say, is diffuse punctate staining of the cornea or chronic epithelial defects. Now, you're not going to get that when you're allergic to Trussopt. It also says it could be irritation, ocular pain, stinging, burning, which you're not going to get with that. So if it was a true type 4 allergy, you would not expect staining, you would not expect ocular irritation, stinging. These would be signs of a toxicity etiology. And here we come. Right. So the terms drug allergy, drug hypersensitivity, and drug reaction are often used interchangeably. Drug reactions encompass all adverse events related to drug administration, regardless of etiology. The majority, that is 75 to 80% of ADRs, adverse drug reactions, are caused by predictable non-immunological effects: irritant dermatitis, epithelial desiccation, drug toxicities. These are, in my opinion, well, they are actually, they're microtrauma. So if we go back to this conjunctivitis medicamentosa, and I make the analogy with the first example we had with the dermatitis, I believe it's two distinct entities. It can be a type 4, or I would call it a type 4 hypersensitivity. So something like Trussopt would give you theoretically a follicular reaction, because remember, it's gone via the lymph nodes. The cornea would be clear, but you still have the swollen lids and so on, but it's itch. And then there's this other, I would call it toxicogenic conjunctivitis. And I think that's a more descriptive term for what we're looking at. And I want to use this patient. This patient, I've known her for, oh gosh, I reckon 20 years now. And I first met her and she came in and said, well, we're just taking a general case history. And I was taking down what drops or tablets she's on, and she says, oh, I get viscotears. I said, well, why do you get viscotears? She says, I've got dry eye. And I thought nothing more of it. I just wrote that all down, said, okay, that's fine. And she was here because her vision was blurry. She didn't say anything else. And it was not until I brought the slit lamp around in white light that I could see this corneal epitheliopathy all across. And I said to her, I said, how often are you actually putting the viscotears in your eyes? She said, well, actually, my eyes are so dry, they're becoming drier, actually, all the time drier, that I'm putting the drops in about 15 times a day. So it was escalating a problem. She had an irritable eye, which she described, or somebody described as dry. So she's putting viscotears in, and of course the cetramide in this case is creating trauma of the epithelium, so it's making her eyes feel worse. So she's putting more viscotears in. But the symptom was gritty, irritable eyes. But she didn't even think to report that really, because she thought that was normal. Right? She thought that, well, she's got dry eye, she's putting the viscotears in. There's nothing really to report. But when we did it, she had pancorneal punctate epitheliopathy. You know, you lifted the lids up, it was underneath the lids. If it was exposure based, you'd expect it to be between the lids, but you lift the lids up, it's pancorneal. So the diagnosis was toxic epitheliopathy. So I left her on a glaucoma drops, which she was also on incidentally, but took her off the viscotears. And it took some months for her vision to come back, because her vision had clearly dropped. But it wasn't because she needed stronger glasses. It was because she was looking through this toxic epitheliopathy. So I think it's important to look at these, because you're going to treat them differently. Well, obviously you wouldn't take someone off Trussopt, but you'd certainly give them a non-preserved Trussopt. Whereas with the toxicogenic conjunctivitis, you would try to eliminate the actual drug used. to get rid of the toxicity and the trauma. So quickly, just some general tips on clinical management plans. You've got to think of your hypothesis, you've got to think of your diagnosis simply as your best working hypothesis. So you're taking a really good case history, you've done a good observational examination of the person, and you believe you know what it is. And it isn't necessary always to put an exact label on the pathology, but it is vital to know the category. And for this, we use this medical sieving, which we're not really taught in optometry, and I think we should. Medical people are taught this way. We are sort of tried to compartmentalize it. We think of a picture in a textbook and we think of what we're seeing, so it must be that. Well, not really the right way to do it. So it's a thought process allowing the clinician to arrive at a logical, supportable management plan for a particular presentation. It is not jumping to a conclusion based on a textbook picky. It is a consideration of all the evidence, positive and negative, from a structured case history and a clinical examination. So there's lots of medical sieves actually. A simplified one for us anterior eye people is what Colin and I call DITI. But that was degenerative. DITI would be degenerative, infective, trauma, or inflammatory, but really there should be neoplasia in there as well. So it's NIDIT, which doesn't sound very good, but anyway. So if you can break it down into one of those categories, then you're 3/4 of the way to actually treating it. And I think the thing is to think about everything in allergy falls into at least into one of two sieve categories really. It's either going to be inflammatory or trauma. It's got to be really one of those two things. So we're going to treat them along those lines. So allergic hypersensitivities, because they involve activation of the innate or acquired immune systems, are always going to be inflammatory because that's the inflammatory process being triggered. And so, you can have all sorts of different treatments, but they're also always going to involve anti-inflammatory strategies, whether it's pharmacological or trigger removal or avoidance. It's going to be along those lines. The red herrings were trauma, microtrauma of GPC, toxic epitheliopathy, and dry eye. And treatment would then be aimed at the traumatic trigger. And so that's why it's important to think logically about what we're looking at, and don't worry about questioning things and think, right, this doesn't look quite like the picture I'm expecting it to look like, but all the evidence suggests such and such. So a final comment on your clinical management planning. You are absolutely entitled to be wrong, as long as your clinical notes are logical. So you start off with your diagnosis, which is your working hypothesis. You come up with your clinical management plan. You put in place your treatment. Then you do your meticulous follow-up. And then as new evidence comes in, you adapt your clinical management plan. And as that author before, when they were talking about irritant dermatitis, they say, if treatment does not appear successful, consider patch testing for an allergic etiology. So they're saying that you're going to treat this, okay, the first decision was to think that it was an irritant dermatitis. So if you start treating it as an irritant dermatitis, but it just won't go away, then you've got to start thinking, well, could it be allergic? And so they're saying medics are perfectly capable of going down one avenue, so long as they meticulously follow up and they say, right, that hasn't worked, I think it might be something else. And similarly, if we treat conjunctivitis medicamentosa as an allergic reaction, but there's no improvement, then perhaps, change the working hypothesis. But I do think it's easier for us, well, maybe not easier, but remember, an allergic type reaction is probably going to be itchy. A toxicity one is going to be gritty. Now, to finally finish off with, here's a quick example. Have a look at this one. Now, you can tell that this was quite recently because the gentleman is wearing a mask. Now, take it from me, I did a good case history, and this came up within 12 hours. It just appeared. And he came in to see me, and the differential diagnosis on this could have been, you're looking at it and you're thinking, crikey, is that preseptal cellulitis? Should I be treating this perhaps with a systemic antibiotic? But all of the signs and symptoms, that was just pure, unadulterated chemosis. The chemosis of the bulbar conjunctiva was ballooning right out. And really, therefore, it was transcending into the tissue, into the lid tissue as well. So I prescribed prednisolone. I wanted a fairly strong steroid because it was pretty uncomfortable and pretty unsightly. I saw him the next day, and within 24 hours that was gone. So this is what I love about independent prescribing. I'm not sure, I don't know how many optoms would deal with that in the community, but this gentleman paid me, I dealt with it, it was all done. And when he thought that these, and of course this is during COVID, so his other option is to drive all the way to a hospital and sit there. So it's great fun being IP, and I hope you enjoy it. Thank you very much.